do some shadowing. We can get her into some shadowing. Okay.
Welcome everybody. Thank you for your attendance today. It's 9 o'clock. We're gonna get started. Everybody's seen the agenda. We have a motion to approve the agenda. Second. All approved? Okay, yes, thank you. The minutes, hopefully everybody has had a chance to review the minutes. Are there any corrections or additions to the minutes? If not, may I have a motion to adopt them, approve them? Yeah. Second. All approved? All in favor? Okay, thank you. Okay. Today we are blessed, I would say, to have Ronnie and Lynn Miles here with the hospital. Those that don't go by it regularly might not see the progress at the old Walters Clinic. Now, Ronnie, I don't know what the proper name is, but I'm on Dr. Holton's clinic. But it is extremely exciting to see the continued commitment of the hospital group in our community. So Ronnie has a presentation. I know Tess is excited about that, being on their board and spending so much time on that effort. So Ronnie, if you will, tell us what's happening.
Sure. Well, thanks a lot. I apologize for those of you your backs to the TV there, but you can turn around and give you a second to do that. But thanks for asking me to come, Malcolm, to speak a little bit about Outer Banks health. Although I just put it out of presentation mode, which is disappointing. I know a lot of folks in the room have been around pre-existing the hospital, but maybe everyone is not, and maybe folks who get a chance to see this presentation or see the minutes don't know that we indeed are a limited liability partnership, a private nonprofit organized through CON in the state back in the late 1990s with Chesapeake Regional Healthcare in Chesapeake and ECU Health, formerly Vidant Health and UHS Health Systems previous to that. We do have a local board of trustees. You'll recognize some of those folks on the group. Our board consists of 10 members, and it is appointed strictly by the ownership of our organization, 60-40. So 6 members appointed by ECU Health, who owns 60% of our operation, and 40% by Chesapeake. And there are standards in the bylaws that require a certain percentage of individuals to be full-time residents. Here in Dare County, you see a couple of those that you recognize, with Jason Wattell here at Southern Bank and Test Judge here in the room. I know you recognize Myra Ladd-Bone, and Dr. Gary Hunter lives in Manteo as well, anesthesiologist at the hospital, been here about 14 years in the community himself. And Van Smith, some things circle around in life, we all know. Van Smith was the president here 14 years ago, went to Greenville for some weird reason, whatever that may be. It was good for me, not for him, maybe, I don't know, haven't asked him. But he is now a regional president for community hospitals, and is kind of my liaison back to ECU Health. He's on our board as well. Pete Berkheimer is a civil engineer in Kill Devil Hills here locally. Dr. Fountain graduated from Cape Hatteras and went to school and came back, is in a position in Avon, and she's on our board as well. Reese Jackson, that's the CEO and president at Chesapeake Healthcare. And then Myra Bowen, who maybe I didn't mention, is from Williamston as well. Did a lot of work on the Cancer Foundation in Greenville and joined our board years ago when we started our cancer campaign to build our community cancer center. I'll talk about our mission and vision in just a second, mainly around wellness and our mission. You know, the forefathers of the hospital were so forward-thinking. They put healthcare and wellness, that is, in the mission 22 plus years ago. Today, a lot of hospitals in the nation are starting to talk about wellness and add wellness, but really thought a lot about how the Outer Banks handles itself as a community of wellness already 20-something years ago. It's kind of helped birth our Outer Banks health coach that we take along the sand from here to Ocracoke and back as well. Center for Healthy Living that we established as well. and other things that we focus on. So not focusing on just inside the hospital walls, as you've seen the growth over the years, but also focusing on wellness and prevention. A lot of great programs with folks in this room. Health department is a great example. Some of the programs we do to make sure every lady in the community can get a mammogram, regardless of the ability to pay, for example, and work with the health department on some of those needs and others. We're really proud of some of our awards. I won't talk about all of them, but we are nationally recognized in a lot of areas. 13 years ago, we didn't have a cancer program, and I saw that cancer mortality was upside down. We were behind the state and national average by about 7% in mortality for all cancers. Today, I'm proud to say we're about that percentage above the state and national averages, realizing that the state and national averages have actually gotten better also, so we've gotten even better than that. We're called a critical access hospital. It's just a category of hospitals. There's several categories in America for hospitals, about 1,400 hospitals in that category. And we are one of only 8 who are accredited by the Commission on Cancer College of Surgeons program. And that is the same exact standards that Centera Norfolk, ECU Medical Center, Chesapeake Regional Healthcare, Duke, Wake, everyone else is accredited by. And we live by those standards, not because we put an award on the wall, but because it's the right care. It's the best patient care, proven over the years of care. There's only one hospital of our category accredited for breast cancer, and we are that hospital in the nation as well. Dementia friendly, we talk about a lot. Marshall Bryant has led that role, came out of the Community Health Needs Assessment years ago. We actually have obviously a nonprofit coalition now for dementia in the community. We were recognized as the first hospital at that time in North Carolina to become dementia friendly back in 2015. And now Marshall Bryant, our CNO, actually sits on the advisory board for the UNC Health System, for the Atrium System, consults with hospitals throughout the state and region, has even talked to some folks in the United Kingdom about our work that we do, as everyone's trying to move to what we're doing, basically train 100% of our team members how to recognize signs of dementia and how to approach those patients so not to agitate them, to be able to give them the best care. Even if you're a facility worker walking in a patient's room, you understand how to react to that patient and how that patient might react to you, for example. And then in 2018, the American Hospital Association has about 4,000 plus rural hospitals, and they give one award a year for hospital leadership. And we received that award in 2018, followed not too far by winning the award from North Carolina Healthcare Association's inaugural Innovation Award in 2019 for some of that work, plus some work we've done with Dare County Center for Healthy Living and Nags Head and others as well. And there's 5 hospitals in the state out of about 100 hospitals that are 5-star hospitals for patient engagement and, more importantly in my mind, overall outcome around mortality, safety, readmissions, patient experience, and timeliness and effectiveness of care. So we are one of those 5-star hospitals. This is independently studied. When you come to our hospital, come to our practices and leave, you get that text message, you get that email, you get that phone call about the care you deliver. That is you telling us the kind of care, the kind of communication, the kind of medication communication, discharge communication that we give you. And one of only 483 in the nation. So you do have a fantastic little hospital here that pays attention to all the right things. 483 in the nation. To continue that 5-star journey, the ECU Health System has about 1,100 providers in the system. 33 of those are rated as 5-star through Medicare, through, again, those same surveys I spoke about. And actually, out of the 33, you have 10 of them. There's 10 of them right here in the Outer Banks out of 33, out of 1,100, just in the ECU Health System as an example. You'll recognize some of those folks, but just some great individuals. I won't read all their names. Feel free to keep this presentation. You can get it forwarded to you, whatever you'd like. Put it in the minutes as well. I'm totally fine with that. And then I'm not going to go into the hospital too much today and the system as a whole. I'm really going to talk about ambulatory world. That's kind of why we're here, talking about healthcare access. Initially for primary care a couple of years ago, we started talking about it in more detail. But just to show you, it's unusual for a hospital in our category to have the kind of services that we have in the Outer Banks. One of a kind, really, only a few of our kind with these kind of services. 28 surgeons, which is pretty amazing. Some of those exclusive just to Outer Banks Hospital. The good news on this slide, with all those providers that are credentialed on our medical staff, which means we have to go through a background test and check liability in cases and all that kind of stuff with each and every provider that comes on staff. Is one great example I love to give is mammography. You know, if you come in for a mammo in an organization, we have a full-time radiologist on site, but they're general. Some things they read, some things they don't. But a physician in Greenville, or they may be in a Hosky or somewhere else, but they're the specialist for mammo, and that's all they do all day long is read mammo. Head CTs, MRIs of the head, and those type of things are actually not read here. They're read other places. A fun story that Dr. Elstock, our local radiologist, will tell you is a good friend of his apologized to him one time and said, "Hey, I'm sorry, I went to Greenville for my CT scan." He said, "Yeah, I know, I read it." And he was here in the Outer Banks. So fiber connected between all the hospitals in the 29 eastern counties through ECU Health. And just a great opportunity, like 6 pathologists that you could never hire at a small hospital when you only can support about a half of an FTE of a pathologist. So just a great opportunity for independent hospital with autonomous board, but still has the connection back to Chesapeake and ECU Health for all those specialty needs and experts. And this is a timeline I won't go into either. Happy to come back sometime and talk about the health system in general, but this is just a quick timeline to busy your eyes a little bit to show you that we just haven't stopped in the last 12, 13 years growing and trying to bring more and more services to this community and to keep people locally. We know the best care is local care. We know preventive care only happens when it's convenient. You're not going to drive to Chesapeake and Elizabeth City to get preventive care and screenings near as often as you would when it's just right here, or when we're out in the health coach checking for screenings as well. And just one indicator, last indicator of how we've grown since this hospital opened here in the Outer Banks. You see in 03 about 161 full-time equivalent employees. Now we've grown to 437, over 500 team members. Some of those are part-time, PRN, a day or two here and there. That's 437 is 40 hours a week equivalent. And now about $50 million in salaries, although the 24 budget is a lot heftier than that because of the costs that we've all seen here in the Outer Banks and the rising in salary and employment. In order to stay competitive and keep team members, we've had to increase salaries more than ever. So let's talk about the Outer Banks Health Medical Group. This is their timeline. When I arrived back in 2011, we had 5 practices. Some of those practices were still independent. 1 or 2 orthopedics and Manteo, for example, were already part of this local hospital, and the others slowly came into the system over a couple of years there. In 2014, we expanded open family medicine in Southern Shores and opened internal medicine in Nags Head. In 2015, we opened our first urgent care in Southern Shores. In 2017, we brought ear, nose, and throat services to the community with Dr. Jackson in Kitty Hawk. About the same time, Dr. Late decided to join Outer Banks as an independent physician, but obviously is credentialed on our staff and does surgery and cases on our staff as well. Worked really well with her. She actually rents from one of our medical office buildings that we own. Center for Healthy Living started in 2018. That program started to work with Dare County employees, trying to maintain their health insurance costs that they were spending on their own team members. So we have a great program with Dare County. We do metrics to look at needs and specialized programs based around their needs within their employee division. In 2019, about that time, Centera left town from Kitty Hawk, and we had a huge need to grow our space that was in Southern Shore, so we built the campuses up in Kitty Hawk and expanded those practices and moved both family medicine and urgent care to Kitty Hawk. And in 2020, when something happened called COVID, we found that our urgent cares were overran with COVID testing, not just symptomatic, but also all those folks who came from Maryland and Pennsylvania and New York and had to go back with a negative test, or they couldn't go back to work where they came from. So we broke apart and opened up our own COVID testing center so we could test folks who were leaving, but they were asymptomatic, so we didn't mix those with folks who were symptomatic patients. And then later on opened the infusion therapy that they were given for a while when COVID started, the patients as well. And through COVID, about that time, right in the middle of it, Dr. Pettibone Pond joined us. Dr. Pond is fantastic, brought urology services to the Outer Banks, and we've added a provider to that practice since then. So that's a fantastic group that we probably need more space here soon. And in 22, we moved Nags Head Urgent Care to a new facility, expanded that facility for size. The flow is so much better than it was in the old building. And we also need to move that building in order to to build the cancer center, connected radiation therapy center as well. And we opened up family medicine Nags East and expanded more family medicine in Nags Head. And are expanding that clinic again, I'll show you in a moment as well. So as you see in 24, we're expanding Manteo, Nags Head East, and also orthopedics as well. I'll tell you about that. So you see all in all about 47 providers, 148 team members, and that's just in the medical group, not including the numbers I talked about earlier, it's in the hospital in general. So these are some of our locations. This is family medicine along the beaches from Kitty Hawk to Avon. And you see patients enrolled, a number of patients on a panel. If you've been in the practice for 3 years, have been seen within 3 years, we count you as being on the panel. You might have visited once, twice, none at all in 3 years, honestly, or 16 times. You just never know. But about 4,000 patients in Kitty Hawk enrolled, about another 3,600 in Manteo here. The star burst means we're recruiting still for those locations for additional providers. Avon practice about 3,500 patients, but they also do some urgent care work down there in the summer, and they also conveniently for Dare County employees in a program we work with Dare County, they see Dare County employees down there so they don't have to drive all the way up here to be seen in our Center for Healthy Living at the hospital office buildings. Internal medicine there with Dr. Metcalf, about 2,500 patients. Internal medicine physicians see usually a lot more acute patients with more illnesses and comorbidities. Can't quite get through the number of patients that normal primary care patients do. And then the Nags Head East practice that we just opened about a year or so ago and are expanding that practice as we speak. So about 16,000 plus patients and growing. I'll show you a slide in a moment that shows you how those are growing as well. So I want you to meet these folks. You may not get to see them much. This is a practice down in Avon. This is Dr. Crabtree, who's been with us. He actually predated the hospital's existence down there in Avon. And Dr. Fountain, who again graduated locally at Cape Hatteras and came back to practice in her community. And she's also one of our board members. But you see that about 11,000 visits last year. A lot of that also, again, is a little different than a pure family medicine because they're seeing urgent care patients and there's Dare County patients as well. They are a little unique because they have they have it on X-ray, have a trauma room, they have a helipad right there at the clinic. Before our recent bridge was built, we did have a lot of time down there. Obviously, that we had some issues with the island being isolated, so they built that center with a generator as well to be able to run that center as long as needed, and for EMS to get there through helicopters and that type of stuff. This is a practice here in Manteo with Dr. Sumners, Worthing, and Baker. Still recruiting for that practice. The hope about 9 months when the back is completed, we'll move into it. In the summer of 25, we'll finish with refurbishing the front half as well. But hopefully, we'll have a provider in line by the time that all happens. Start adding some providers to the Manteo practice here. But about 8,000 visits last year. This is the new Nags Head East family medicine practice. Dr. Sanchez works between it and the urgent care in Nags Head both. Dr. Woodard is coming. He is signed on. He'll be here in October. Has some strong ties, his wife does, to this family, and will be here, we think, now long-term with us, which is great work. And then we have Rachel Johnson, Thomas Ferguson, and Alina Sevier as well. This practice is a little different. We've tried a new model because today it's easier to recruit advanced practice providers than it is MDs from a shortage perspective. And from a primary care perspective and the kind of money the primary care doc makes, it's not that lucrative. More physicians are going into specialty practices today versus primary care. Traditional model, if there's a MD in a practice and an APP, as we call them in a practice, advanced practice provider, then they'll have their own enrolled patients and they won't really talk that much in between. They'll work pretty independently. Well, this practice doesn't work that way. This practice, Dr. Sanchez and Dr. Woodard will have really small panels of patients so they can do what we call elbow support. So they can work hand in hand with these providers every day as they see patients. And as a patient may have more acuity, may come back from a hospital visit, they may see the physician for a number of visits until they feel comfortable they can go back and work with one of the APPs. What America is finding is a lot of nurses are going back to school to become nurse practitioners, and folks are going to PA school, and we're turning out a lot more of those providers than MDs. But a lot of them are new. So this is a great way where new graduates can work with seasoned MDs and they can really talk daily about every patient that they see to help guide these providers. Dr. Metcalf was around for a while. He may have predated the hospital. He was with Healthcare East for a while. That practice made some changes when we went through hospitalist programs for pediatrics, and he came out into internal medicine practice of his own, working for us there in Nags Head, and Marina Turner there. You see, he still does a few home visits. Dr. Sumner's here also does some nursing home visits herself and a home visit as well. You see these funny little smiley faces, by the way. We do a lot with growing our own. If you see these faces, Sarah Summerton was a nurse with us at the hospital system and went back to school, became a nurse practitioner, and stayed with us. There's about 4 or 5 that we have kept, we have worked with over the years, and their schedules, they could go back to school, and once they became providers, and they wanted to stay with us as providers, which is fantastic. This is Kitty Hawk, has the most primary care visits of any practice to date. I believe Manteo is going to exceed that sometime next year or so, but right now about 8,300 visits a year. This is just one slide that talks about the primary care visits overall per practice. You see COVID 20, 21, and 22. We had a lot of drop in visits around COVID, people afraid to get out, afraid to go to the clinics. We also did do a lot of virtual care and telehealth care there as well during those times. And then 22 was a significant drop that we had here in Manteo that attributed to that drop as well. But you see this past year, we're at fiscal year October 1. So this is last year, 23 fiscal year. We exceeded the number of visits we've ever done in history at about 39,000 visits in the primary care practices. So you see there again, kind of toss Avon out, it's a little different, but Kitty Hawk and Manteo neck and neck, about 8,000, they're our 2 busiest practices. And we talk about specialty care briefly. Specialty care also dotted across the Outer Banks, ear, nose, and throat there in Kitty Hawk, and orthopedics there in Kill Devil Hills, and urgent care in Nags Head, urgent care in Kitty Hawk that we're recruiting for additional providers for. General surgery, women's, and center for healthy living are within the office building at the hospital proper, and recruiting for additional OBGYNs and providers for the center for healthy living as well. And then our urological practice. I think if we had room right now, we'd probably be recruiting for additional provider there as well. We just don't have room in that practice. This is Dr. Pond and Ariel Berry as well. Dr. Pond, fantastic clinical provider, fantastic person in general. About 6,000 visits with those two ladies. You see the surgeries and about 1,000 in-office procedures as well. And it's urology, so somebody made a joke when they helped me with the slide. There's 5 bathrooms in urology. Some of those are locked down for flow testing and stuff that they have to measure and monitor. So, but yeah, 5 restrooms. So, still recruiting for women's care. Dr. Dwyer, who doesn't know Dr. Dwyer, if you've been here any amount of time at all, he also predated the hospital, was seeing patients down here and delivering patients back in Elizabeth City. And Dr. Dwyer is now part-time in the clinic. He is a vice chair, medical director for the system for the community hospital. So he does a lot of work now, taking things that we've done here locally and standardizing care and trying to grow that throughout the community hospital. So he's working with medical staffs and presidents throughout 7 or 8 community hospitals within Vidant now. But then you see Dr. Haig and Dr. Molina. And Anna is, again, another provider. She actually started as a ward secretary for the hospital years ago, and then went through LPN and nursing, and now a nurse practitioner. Now a physician's assistant, sorry. And then Laura Case there. A lot of visits there, 11,000 visits almost, plus 271 deliveries and 73 C-sections on top of that. So really, really busy program. We'd love to expand more and more into GYN surgery. Right now they have their hands full delivering kids. So it's really hard to grow. So we're trying to grow that practice to help cover call a little bit, but also to help with some GYN surgery locally. A lot of work with the health department in that surgery as well. Dr. Haig, Dr. Jenkins are 2 general surgeons. Dr. Jenkins was in Elizabeth City for 30 years. Came to work with Chesapeake, and we don't employ physicians locally. All the team members within our medical group are Outer Banks Health team members, and the physicians are actually within either Vidant Medical Group, well, ECU Health Medical Group now. Our Chesapeake Regional, this is one, for example, Dr. Jenkins is a Chesapeake Regional Medical Group physician, but we have a contract back to our owners where we employ them locally and pay for them locally. But just great opportunity there to have two different facilities that we work with. This is at Center for Healthy Living with Dr. Bowen. She is also part-time now. She is the Chief Well-Being Officer for the entire ECU Health System. So Dr. Dwyer is making a difference in 20-something counties. Dr. Bowen is as well. Dr. Terry Berry, he used to be at Family Medicine in Kitty Hawk, left and is running occupational health for the entire ECU Health System. So some great talent here locally that are doing great things in a regional perspective. You see there the visits they have as well. And still recruiting for that practice. This is our 3 orthopedic surgeons. Dr. Chase also predated the hospital here. Dr. Chase there, McKenna, and Dr. Mann, fantastic group of individuals, over 8,000 visits, about 400 surgeries as well. And I'll show you in a minute, we're going to expand that practice as well to be able to get more patients. And we have a pretty long wait right now. It's a tight facility with not quite enough exam rooms today. And Dr. Jackson, the first ear, nose, and throat surgeon on the beach, and Dr. Fulmer is a audiologist as well. You see the visits there. The urgent care in Nags Head, again, Amanda Williams worked with us as a nurse at one point and became a nurse practitioner. You see the other nurse practitioners and PAs there. About 18,000 visits in 23. And yeah, Dr. Sanchez started years ago a frame display of fish hooks. So he's got if you ever go and you want to look around, you can see a bunch of fish hooks on the wall. He's taken out of individuals over the years. It's interesting. But a big practice with 19, almost 20 FTEs in it, and 22 in Kitty Hawk, and we're still recruiting there for Kitty Hawk as we speak as well. And again, Ben Riley was a nurse in the emergency department years ago and became a nurse practitioner and decided to stay working with the system as a provider. And this is just an overall slide of the volume. You see there what COVID did to us in 2021 and 22, mainly focused on the urgent care centers. And in 20, we saw 40,000 visits in Kitty Hawk. In 21, we saw 57,000. We saw 17 additional visits, 1,000 visits. I mean, the flexibility of the team and the providers is just amazing how they could handle that over the years. So you see the urgent cares actually see the most folks, obviously, and then all down with some numbers there. And again, women's was the biggest practice there at about 11,000 visits. And we're continuing to grow. You've probably seen it, but this is the new Manteo site. Far right of the building is the original building. This faces 64, so you'll see access facing 64. We have a long ramp now that's not quite probably up to date today for ADA compliant, and this will be, so we have a lot easier accessibility for wheelchairs and walkers and canes and that type of thing in this practice. And we'll double the size of the building. On the right-hand side is the blue is the current building, although it's not the current floor plan of the building. Because what we'll do is we'll build the left-hand side, we'll move those providers and staff in the back-hand side, and then we'll go back and gut pretty much so it all flows correctly and rebuild the entire front half. I'm going to put a couple of unique things in here, a telehealth room. We do telebehavioral health already in 3 of our primary care practices and in our women's practice as well. And we're going to have a dedicated room there so it doesn't conflict with regular exam rooms. And then also annual wellness visit. We do work with Medicare patients and nursing those annual long-term wellness visits, spend over an hour with the patient. We have a special room for that too, again, so we don't take up exam rooms for patients that are coming in and out. But it's going to a little over double the size of that building. It'll end up being our biggest building at about 7,004 or 5 square feet. The 2 urgent cares are 6,000 and a little bit of change. And this is the site today. They are laying the foundation, starting on it, working on it as we speak today as I rode by. So again, about summer of 25, we think is an estimate. You've all been in construction and seen construction in the last couple of years. So we'll see how that holds out, but that's about what we're thinking. This is 4917. I think maybe the last time I'm going to say it. It was a former Hammer building, OBGYN building. We're trying to get away from that. But it's 4917. This is our Nags Head East primary care building location. This is the entire floor plan. Ignore the white on the left. That is our infusion center there as well, and Dr. Late's ENT practice as well. But we're currently in the gray space with Nags Head East and Beach Medical. You may know Zoe took that practice and moved back to Kitty Hawk where they originally started before Centera asked them to leave years ago. And so they opened up the space for us conveniently. So we are, as we speak, knocking walls out and moving into that space as well. Again, providing a special telehealth room and also annual wellness room as well. But we'll expand that space so we can add 2 or 3 more providers in the long run in Nags Head East. And then this is orthopedic practice. Currently, the orthopedic surgeons have 3 offices downstairs, and far left that building is a small upstairs area that's not finished, and we're finishing it as we speak so we can move our provider offices upstairs so we can have 3 more exam rooms downstairs and get more folks in and out quicker and not be limited to exam rooms. And we did start this primary care access number probably over a year and a half or so ago. We found that everyone in the community just calling the different practices and shopping around just didn't work. We were conflicting and putting folks on different schedules and different practices for hold times and that type of stuff. So we have one individual who does this work, only one, so it's all concentrated together. She knows what she's doing. Nobody's kind of looking at the schedule at the same time, multiple locations. Since we started this line, and since about June of 2 years ago, we've established or reestablished about 5,300 patients, about 2,000 of those or so right here in Manteo who came back on the rolls, but about another 3,200 who are brand new patients who didn't have primary care in this community, who some were going out of town, some were using urgent care, but a good portion told us they were new to the area in the last couple of years. We haven't really seen our school system, some of you may know better than I, but enrollment changed dramatically, with 55 and older populations definitely changing. That's what we're seeing when folks are calling us for primary care. We have another 414 patients on our schedule right now that are waiting on their visit a month to 3 months out, according to what provider they chose. And about 190 patients who right now we're calling back and start getting the schedule work done for those 190 patients, because we do still have patients calling us almost every day. And maybe after this presentation, a few more will, which will be just fine. And then these are coming new providers since 22 in the last 2 years that we've recruited. Doesn't include folks we recruited for the hospital itself, but these are again all ambulatory providers. I won't read through all of them on the screen, but primary and specialty care. I will talk about recruitment. We are still recruiting for primary care, oncology, and OBGYN. Those are all replacements. And some of the folks on this slide are replacements, and some are totally net new providers in the community, obviously. Dr. White has been doing his cardiology practice for 30 plus years out of Elizabeth City, has some APPs here, and he visits here a day or two a week. He wants to kind of retire finally, so we're trying to recruit our own cardiologist. He is an independent practice and doesn't work for us directly, but he is credentialed at the hospital. So we hope to bring a cardiologist in so he can retire out and we won't miss a beat there. And then neurology. Hospitals do everything around physician needs assessment and population ratios. There's a lot of federal rules and regulations on how we can pay physicians. So it's a fair, competitive environment throughout the United States, and hospitals with a lot of money can't just pay docs 3 or 4 times what they're worth just to get them to their locations, for example. And we only had the need for about a part-time neurologist for years. And again, based on the growth we've seen at 55 and older over the last couple of years, we now have a need for 1.2 FTEs in neurology here in the county. So we've opened up a recruit and to start a brand new practice for neurological services as well. And we'll see how that goes. It's a tough recruit nationally, but we are out there looking now. There's some additional APPs as well, you see there. Some of the things we're doing, a few recruitment highlights will end the presentation here. Third year ECU medical students are here. Matter of fact, one's in Manteo right now as we speak at that practice. A lot of great local high school events. A couple of these pictures show that. Top right, a large full-size operation game for high school kids to play with, and also inserting some catheters into pig bladders in the bottom left as well. At Dr. Pond's office, we had 20 for our Innovation Day a couple of weeks ago here locally from 20 students who spent a full day with us, not just seeing about, respiratory therapists or physical therapists or nurses, but also they went in the back of the hospital and saw the chillers and the boilers and worked with the facility director and understand that healthcare engineers and electricians and plumbers are different than residential plumbers. And environmental services is a lot different than cleaning homes because you're really making a difference keeping the environment safe and away from infection and that type of stuff. So we talked to a lot of groups, but out of the 20 students who came to see us, 5 of those reached back out to us afterwards, 3 for shadowing and 2 for junior volunteers. So if we can get 5 students out of 20 every time, I'll take it. We definitely have some folks who work with us as volunteers. We gave scholarships 2 years ago. One right here from Manteo, for example, who's now a full-time occupational therapist with us that grew up, born and raised in Manteo, and then went to school and came back and working here with us locally. So just some great stuff. We're doing preceptorships with our advanced practice providers. Growing our own, we talked about growing our own with some of our nurse practitioners, but we also grow our own from CNAs to RNs to therapists to surgical technologists and others as well. And then fellow rotations with folks from ECU specifically as well in some of our different practices. Working right now on an oncologist to try to get down here to do some rotations as well. And then we do a little recruitment locally. We do some social media and that type of stuff. But the bulk of the work is done from the ECU health system. They've got 8.5 recruiters full-time, media coordinator, email campaigns, Google ads, all that type of stuff. Look through databases around the system. They know every physician and provider who's going to graduate and when they're going to graduate. We customize local visits and interview. Usually it's a 2 or 3 day interview for a provider who comes down. Steve Bassnight is fantastic. For example, we had one who had young kids who wanted to see the school systems, and he spent like 2 hours with them in the morning, taking them to every school and talking it through them. If they have other things, if they want to go to Mommy and Me, if they want to meet other families with young kids, they always have community tours and spend a full day with us and a couple dinners with us and physicians as well. Generally, we let them do one dinner with physicians without any of the admin team involved, so they can feel like it's a really open conversation about how we treat physicians now we've worked together so well. So a lot of good stuff going on there. They do a lot of innovative work, partnering with digital advertising agencies and aggressive online marketing. They do a lot of geofencing work when they're at conferences and such. They purchase all the Google search terms, which gets us to the top of the list when docs search for positions. They travel, obviously, to national conferences, national email campaigns where you can actually see if I open it up. I kept going back to it and opening it up. After 3 attempts, I've opened it. Then they get bombarded with more material because they're interested. They go back to it and go back to it. They'll also send them video cards that highlights the hospitals when they open them up as well. Of course, text messaging, all the local stuff that residents and fellows are doing today because they're definitely not picking up papers or looking through postcards. And all the virtual fairs that they work with as well. So just since October, just the last 8 months of our fiscal year, the system's recruited 99 providers. About 13 additional, not through what I just spoke about, but some of those are residents and fellows. ECU Health has one of the highest retention rates in the nation when it comes to medical schools who keep folks after medical school. And if you remember, they were founded being a primary care medical school really, but have expanded over the years to a lot of specialties as well. And they already have 19 acceptances so far. This is again for the 29 counties, obviously not just for Outer Banks. And right now they have 160 searches open, so they're really busy, a lot of searches. And they beat the average times for fill rate as well as an average across the system. So that's the conversation. Happy to answer any questions about it. Just want to give you some highlights. Again, Malcolm, I'm going to come back sometime and dig deep into the hospital and the services on the acute side and the hospitalist program, pediatric hospitalist program. Happy to do that as well. I really want to focus on ambulatory care for today's presentation.
Wow. Ronnie, I appreciate that. Does anybody have any the presentation and thoroughness of what the hospital group now is doing? Does anybody have any questions on that? I'm sure there are. But obviously there's been a lot of work and is continuing a lot of work in the medical field. I'll put a note in here. For some of us, our families or we have been involved in the hospital from the inception. And Russell Langley, I don't know who in the room remembers Russell Langley. Okay. Russell, before the hospital was here, before there was medical care like we have today, he had that dream, as did my father. My father was on the Blue Ribbon Study group to recruit the hospital, had a connection with Chesapeake, I think is who it was. And Bobby Owens was involved in this, as was Walt. And there are others. So I know that we that are sitting here around the table that are looking at the presentation, some of us can remember going getting a fish hook. Michael, did you ever get a fish hook from Walter's office? And going back to Harvey, Dr. Harvey? Dr. Harvey. So it has changed and is changing, and it's great stuff. So we try to get out of here in an hour, and I know we could open this up and talk for another 2. Betty, what would you like to add?
I don't have a question, but I just wanted to thank Ronnie. He was very informative. Being here all my life, a lot of services I didn't know until just now, so we really appreciate it. Very, very informative.
Yeah, thank you very much. By the way, Thursday is 13 Thursday, so I'll be here 13 years Thursday. I had folks like Mike Kelly, for example, who every year asked me when I was going to Greenville, and I'm not. I never am. I've been born in rural America. Besides training as a respiratory therapist in a 1,000-bed system, I spent all my life in rural America and went straight to rural healthcare. Rural healthcare is just special. What we can do quickly is amazing versus a big system who has a lot of red tape, a lot of hierarchy in it. But being able to see the differences that we've made in this community when it comes to cancer and mortality and saving lives is just, that's why I get up every morning. There's no other reason to do it. As hard as it is, as difficult as it is, with more vacancies today and more travelers than ever because of healthcare and how it's working today, it's not that fun at times, but the reward that we all get, that's why we do it. And growing's been fun, and we'll continue to grow services as we can that are appropriate, that we can do excellently. We're not going to ever do heart surgery because you don't want to do that with somebody who does 10 or 20 a year. You want to go over there and do 200 or 300 a year, those type of things. That's hard for the community to understand sometimes, especially folks who retire here from bigger cities and have every specialist available that there is to man. But it's been a pleasure. It's been a real pleasure being here for these 13 years.
I will add too, I had 5 of the 7 grandchildren in that house. The other 2, Margaret, she was in Raleigh at the time. Anybody else want to do?
I just want to make a comment. You mentioned fiber connected, and it's really what you just also reiterated with the specialists. You can't have just an incomplete source of specialists in every single facility. It doesn't work. But the truth is that in rural, as you well know and have maintained your presence, we're rural or remote by choice. Whether it's Kinston or whether it's Avon, you're probably either generational or you got there as soon as you could. But that means that in some cases, if you came from somewhere else, you're going to have to come to grips with sacrificing some of those conveniences. But you're fiber connected, and the way that you're aligning all of these specialties throughout, I think that's really wise, because that's going to be the way to keep everyone so that they're connected with the specialists they need when they need them, but everything else to support. And so I commend you on that one for sure.
Yeah, thanks, Michael. Yeah, we could talk about the hospital sometime. We do telepsychiatry. We do teleinterpretation for folks who speak different languages, teleintensivists for folks who can work at our ED and the med-surg for patients who maybe need more care, but we can't handle it locally, and how to get them somewhere quickly as well. And a couple of the teleprograms as well, the behavioral health as well in the practices. Telehealth is going a long way, but you can do just so much with it, but we're trying to use that technology as well. Yeah.
All right.
Mr. Chairman?
Yes, sir.
Two things quickly. Thank you very much. Very informative. I appreciate that. You partially answered one question that I am asked fairly regularly, and that is urgent care in Hatteras Island. Whereas I can't tell you how many people come up and say, we need urgent care in Hatteras Island. All right, well, you referenced the Avon practice doing some urgent care.
Right.
Is that expandable? I mean, what's the right answer to these people? So
Yeah.
I quit making it up as I go along.
Yeah. Currently today, Dr. Hodges retired early in the calendar year this year. So right now, Dr. Fountain and Dr. Crabtree are handling it on their own. We do have a temporary provider coming in to help with the summer. And they should be doing some walk-in care for their panel, for their established patients. But otherwise, they just can't handle the capacity. I think once we get our third physician recruited again, they'll open back up for some urgent care once that happens. But right now, because it's just two providers, it's pretty tough to do that.
Okay, thank you. That helps.
Malcolm left, we're done.
I want to share a short story of what OBG has brought and the Outer Banks Hospital has brought to the Outer Banks. About 30 years ago, yeah, she's 30, 31, my niece was born in Nags Head. And I don't know if y'all remember the little urgent care we had, where the community clinic is at now. We were at church, we had to drive her to that urgent care, and she was born right at the entrance door where the ambulance used to back up. They didn't have any blankets, they didn't have anything for labor and delivery. My niece was born around 9:30 at night. They wrapped her in the paper that they put on the stretch, for patients to lay down. They wrapped the baby on there, put her and my sister, didn't cut the umbilical cord, put them on a helicopter and flew them to Virginia. So that's how far the hospital has gone and Outer Banks has gone in here. This is 30 years ago.
Say one thing. We are so grateful at the Community Care Clinic of Dare for the hospital support and financial support and development council support through their grants that help us with direct patient care services. And now that we have dental, we're going to talk to the emergency department about referrals because we do take emergency walk-ins, and we're really grateful and appreciate the partnership.
Thanks, Lynn.
Also, as part of representative of the school system, want to thank you for collaborating, coordinating, and doing all that wonderful stuff with the school system. The kids that came back from the trip were just, over the moon, talked about it for days. And so I really appreciate that collaboration, because I really think that is an untapped gold mine for you guys and for all of us here. So thank you.
Thank you.
Ronnie, I appreciate it. If you need to leave, that's fine, I understand that. But if not, we have Franklin Walker on the phone. Maybe not. I see him, but he's not nodding his head. There he goes. Franklin Walker, you're up next.
Malcolm, I just wanted to say, my necklace broke. I'm gonna pick up the beads, but be careful.
primary care become part of our precepting hub. So we're going to continue to have some discussions about that, and that's great. Feel real good about that. And I have an ask that I've had out for a while, and I've spoken with some of you, most notably Malcolm and Randy, about the need for ambassadors down there in the town. An ambassador will be available to, on occasion, show some of these students around town, take them out to dinner, take them out to lunch, which will be your opportunity as a town to really make the sales pitch to these kids as they come through there. And then hopefully that will pique their interest to come back when they're done with their residency. So I would encourage any of you at the table or anybody that you may know that might want to be an ambassador to contact myself or Malcolm or Randy, and we're happy to set up a call to speak with you. Malcolm, that's all I have to say on the update. I'm ready to accept any questions.
Does anybody have any questions? Okay, the one observation in the preceptors is housing taken care of. Is there a need for housing?
You're breaking up. I heard you say something about housing.
Is there a need for housing for the precepting program for the students?
Yes. We continue to want to recruit or encourage people within the town that may have a spare room, an apartment, to contact us if you'd like to allow one of these students to stay in your apartment or your house for a few weeks while they're down here. Both Malcolm and Todd have already volunteered, and I would love to get some more folks from Manteo again to be involved in the house. Right now, we're going to house the Campbell students in Englehart in a rental house.
Okay, anybody got any questions? Okay.
Franklin, good morning. You talked about the flow of students to preceptorships. Could you be a little more specific? Campbell sending the first PAs, and what do you envision see for the fall going forward?
Okay. Well, I'm sure Campbell is going to continue to send their students. We have agreements in place with Wake Forest PA School and Elon PA School. And we're working on finalizing agreements with UNC. One of the problems with UNC is their placements have gotten to be almost 9 weeks, which is pretty tough for people to accept a medical student for 9 weeks and teach them continually for 9 weeks. As of January, UNC is going to roll that back to be much shorter, Randy, so I think that will be something that our preceptors in Manteo will welcome, okay? And now with the partnership with Lynn Miles and Outer Banks Health, she and I are going to have a follow-up conversation on Friday to see what housing they may have, what schools they're working with, if any, and we will continue to recruit medical schools. Our emphasis will be on state schools first, and then we'll go from there. And part of the grant that they award, Randy, was that you have to be, as a teaching hub, precept both MD, DO, and APP, which could be PAs, nurse practitioners. And so that's what we are preparing for.
Thank you.
You're welcome.
Or anybody else? Okay, Franklin, thank you a bunch, and we're real excited about where we're going to go with this program community-wide.
Okay.
All right?
Great to see you guys. Have a great day.
Jay.
See you.
Okay. I'm going to do something real quick because I know Randy has to leave. So I'm going to change the agenda just a little bit. I feel like it's a need to have a vice chair. I've been doing this a couple of years now, and I don't think the chairman should stay forever. It's kind of like an old fish. You need to throw them out after a while. And Randy has been involved deeply from the beginning. He's the quiet hand, the calm hand that guides me. And if there's someone else that would like to be that vice chair, please speak up now. If not, I'd like to have while he's present, because he's getting ready to have to go to a elections meeting, and I know he'll probably want to vote against himself. But if I could have a motion to, okay, is there a second? Right. Any discussion? All in favor? You can leave now if you need to.
Sorry, I will speak up. Thank you for reminding me. We did have retirement of the director, Jackie Tillett, who's been very valuable and will be missed. We're interviewing her successor at 10:30, and there are legal requirements like I have to be in the room that the state board imposes on us, so I will have to leave no later than 10:15 to get over there. I apologize and hope that does not disrupt the flow of discussion. It will probably make it shorter if I'm not talking.
Okay. Randy Hamilton, will you give us a report of what you've been doing? Okay. Does that allow questions?
Not in 3 minutes. Hold your questions to the end. We've been pretty busy in the mental health and substance use subcommittee over the last period of time. I'm just going to go through the dates and the meetings that we had and just a highlight of what we were talking about. I will say that all of our discussions have primarily been focused on mental health substance use facility availability, also then transportation to reach those facilities, how you get patients there, and then the overall coordination of efforts. And if you remember our last presentation here, we talked about all those things and we moved off smartly and hopefully started addressing those kind of issues. We had an ad hoc meeting with the Blanchard Institute on 4/18. Randy Finninger, Malcolm Ward Blanchard, and Michael were at that meeting. We talked about the possibility of some sort of a partnership in the region. We've had similar discussions with Joe Rothenstein and his organizations about the idea of a regional approach. Talked about places like Portsmouth and Swan Quarters and places like that. But those were just very broad discussions. So that meeting kind of fleshed that out a little bit. And that was, again, on the 4/18. The working group met on 5/8. Randy, Sheila, and Chuck, like I said, were there in that discussion. The discussion primarily focused and involved on talking about coordination of efforts, specifically something we talked about here, using Saving Life Task Force as maybe a point that could help in coordination. We also talked about transportation. Of those two, Sheila then suggested that she go ahead and get a coffee meeting together, and we all went over to the front porch, and when I say we all, Sheila, Randy, myself, we had Wally Overman there and Roxanna Ballinger, and we talked a little bit about our backgrounds, experience, and then kind of our shared thoughts on how we could move forward. Wally, during that meeting, eventually suggested that maybe the first step forward would be to look at the transportation issue, because that would be something that's easy to identify and we could address as an issue. So he's put that on the Saving Life Task Force agenda for next week. So that will come up in the discussion on that. During the meeting, the working group meeting, Sheila then commented that an issue paper had gone out and have been sent both to the Dare County HHS and Saving Life Task Force on the transportation issue. It really boiled down to when people volunteer to move people around, how much do they get paid using their own POV, taking their own time, putting the gas in their car. HHS had been paying them the mileage, not mileage, and paying reimbursement for the fuel burned. But of course, that doesn't pay for oil and wear and tear and all that kind of stuff. So a suggestion was that we use the IRS rate of 67 cents a mile to reimburse people when they voluntarily transport people. Sheila's kind of took that and said, I think we can make that happen. And so that has moved forward at this point as well. And Sheila, you can expand upon that now if you'd like to. I don't know if there's any comments you want to add at this point.
Well, I wouldn't say there's any magic at what I was doing. It was just using the some of the opioid settlement funds that have been set aside and working with. There's an allocation that's already been approved by the commissioners to support social determinants of health initiatives that come up for folks who are seeking treatment from opioid addiction. So a portion of those funds that have historically been used for transportation will still be allocated for transportation, but now broadening that instead of just doing gas receipt reimbursement to be able to cover the mileage. So I think it's certainly better for those who are doing the transportation to account for more of their expenses.
That was very significant in keeping the volunteers engaged. Now, truthfully, a lot of volunteers just do it and don't take any money. But where it makes a difference, it's important to have that. Then we also had a discussion last week on the 4th, 6/4, with Brett Dunning, Changing Tides Director. He has a facility at Changing Tides. I think that's in Kill Devil Hills. He had been living in a part of that facility. He is now moving out. He's projecting that he could set up a 10-bed detox/mental health location. Now, they are for-profit, so there's a lot of questions between what the possibilities are and what we may be able to move forward with. But a partnership, maybe with a group, the county, the nonprofits, is a potential. Randy and I are going up there next Tuesday to look at the facilities and have a chat with them about next steps and what our thoughts are, what can be supported. So that is kind of what we've been doing over the last month or so, and it's been kind of busy, and I think we've actually got some good traction. Questions?
Any questions from anybody?
Yeah.
I'll just make a comment. I want to personally thank Sheila for assisting in organization of some of these meetings and activities, for calming the fury and angst that exists sometimes among volunteers, and slapping me down when necessary. But thank you so much for what you have done to facilitate this.
And yeah, and I'd like to thank you as well. The other thing that's important, though, that I wanted to mention is that when Wally and Roxana said we will take this transportation as a issue to discuss, it kind of shifts a little bit in my mind anyway. The Saving Lives Task Force, instead of just being an information and educational and sharing, to taking something that they're going to act upon. So I think that's pretty exciting. I hope that.
One question, Randy, on outpatient detox.
Yes.
Any other ideas
About that?
about that?
Well, I think it is a potential, and that is something that Ward really pushed for an understanding of. And I think a satellite facility anywhere could operate that. You could operate that. The Changing Tides could operate that if we had a facility that could then take care of that, because it could be done as outpatient. We could use telepsychiatry to do that as well. I will tell you, though, I don't think that most people, and I think it was not Todd, I forget who was commented about it, about people don't really understand outpatient detox. It is an option. Everybody thinks you got to go to a facility.
Right, we have 5 patients now using Vivitrol.
To go in.
No, that Vivitrol is, you use that to be off everything. But if you're on Suboxone, you have to detox in order to go on Vivitrol. 2 of our patients are inmates, and so they get their first or second shot before they transfer out. But that program's going really well.
I think that remote detox, the levels, I didn't know this before, there's 1, 2, 3, 4 levels, and the first 3 are outpatient, and for anything that you need to detox off, the outpatient seems to be a good way to go about it. And I think there's a real opportunity there too. But thank you, that's actually something I can focus a little more.
All right, anything else? We were going to have, as part of this discussion, Dare Challenge come in and tell us what they're doing. And they're doing some exciting things. But the accident that occurred yesterday from the Dunkin' Donuts, one of their key employees was involved in that accident and died. So because of that, they're not going to be able to present today. Those that know what they do know how great of a job they do, how important they are in our community in a lot of different ways. So if we can lift them up in this time, and Dustin assured me that they will be glad to come back and crow a little bit about what the accomplishments that they are making. I'm going to go into public comments now. And Joe's here today. I don't know, Joe, if you want to give us any update on anything? What you doing? Come on up front.
Hello. Is this working? Okay. So I'll just try to give you a quick update as what I can. As Franklin kind of spoke about the preceptor program, we did apply for that and did get accepted into the AHEC program, which was nice. We were and still are looking for other partnerships in regards to doing those preceptors because so far we've signed to an agreements with UNC, Campbell, and Elon. There are going to probably be others as we move forward, but at the start, that is the initial. We've been able to secure housing for people to be able to come over to Ocracoke as well as Englehart in Swan Quarter, which was really nice. So we're really looking to expand that further also into Manteo as well. So one of our nurse practitioners up here is interested in being able to participate in that program. So that'll be good. Again, we'll be, I think, kind of focused a little bit on the housing side of things. Some of the other things that we have going on, we do have a nurse practitioner who is departing. Lauren Gaines will be leaving at the end of July. That announcement has been kind of made, but it's going to go out formally to her patients here over the next several days. So that is going to be occurring. We do have another nurse practitioner who's going to be coming in to replace her. And whenever that gets finalized, I'll be happy to share that with everybody. We are still looking to do more expansion in regards to mental health services. So one of the big things that has come along from HRSA, that's our federally governing body, there's a $1.1 million grant that we've applied for expansion of mental health services. So that'll include things like working with people inside of Dare and Hyde County for not MAT, but Suboxone, Vivitrol, and things of that nature. And that includes hiring on a FNP, or excuse me, a psych NP, or someone along those lines to provide psychiatric services. So we're at the very fledgling stages of that. It's a 2-year program, and it's meant to develop mental health services. So as we move forward with that, I'll make sure that I share it with the people on the task force. And yeah, we've been able to, we'll have our first year coming up being open inside of Manteo. As you know, we're a very small operation in the cog of things that happen in healthcare. But uniquely, we've been able to see about 3,000 patients in our first year of operation. So that's really been great. And really, again, our focus is always going to be on trying to serve the underserved. So for the people who are uninsured, underinsured, Medicaid and Medicare, that remains our focus, and it's going to. Our pharmacy here in Manteo is a closed pharmacy, and that will open up at the end of this month. So that's been that's been a lot of work. And now we have a pharmacy at each one of our locations in Ocracoke, and in Englehart we've had one there for now several years, and Manteo also. So both the one in Englehart and Manteo are closed pharmacies, so they service only the patients of the pharmacy. Ocracoke is an open pharmacy. That way it gives people who come to vacation there an option as far as being able to get the medications if they forget them at home or whatever the case may be. So we have a lot of good things that we've been able to accomplish over the past couple of years. And I think that there's going to be more growth as we move forward and trying to work with the people in this community. And that includes working with ESS, that includes working with the hospital system, and that includes working with people like Lynn and the task force. Because it's going to take all of us to try to service the people that live and work in these areas. So we're very excited about all of that, and yeah, that was my update.
Anybody got any questions? Let's see. Okay. I'm gonna go around the room. We're a little bit late. Maybe 10 more minutes we'll be out of here. But any comment or concern or observation from the task force? Now's the time. Okay.
Speaking of mental health, I wanted to just let everyone know at the community care clinic, we have a virtual mental health pilot project. We have 10 patients enrolled, and we have anything from an LCSW to a mental health nurse practitioner, psychologist, psychiatrist, and licensed substance use counselor. We started that initially so that we would have a one-on-one licensed substance use counselor for Vivitrol patients. But for mental health, it's going very well. This program is only $12.50 a month per patient, and it's unlimited. We have one patient that meets weekly with their provider. It also includes coverage for everyone in the household for that same rate. So $12.50 a month, anybody in the household. They have bilingual providers. It's so far really wonderful and easy to use. The whole North Carolina Association of Free and Charitable Clinics is looking at this model. So that is available. Our pharmacy is open if someone is eligible. They can use the pharmacy. We're adding optometry with Dr. David Sproul. He's a volunteer optometrist, so we'll be able to do eye exams and then access glasses for about $25. And we have a physical therapist now 2 days a month. So lots of add-on services for uninsured, underserved folks.
And can I ask you to expand a little bit about your virtual mental health? Because we've talked about this at the hospital. They're doing that now. The good and the bad. What's the good and the bad then?
The good is that for our patients, they have no access. They can't afford to go to a private mental health provider. I had a talk with Dr. Richard Martin about the virtual substance use counseling, and just said, is this a good thing? Is this better than nothing? He said, absolutely, it's better than nothing. And it's a requirement that patients sign if they're in the Vivitrol program. They have a contract. So people come into our clinic and they are in one of our private exam rooms. We have a large telemedicine machine, so it's a large screen. They can meet with the same provider each time, so they develop that relationship. And we're doing pre-visit surveys and post-surveys. And so far, the virtual, it has not been an issue for the patients. They are thrilled. The only problem that we've seen is there's a little, by the time that we have to turn the patient's name in, they have to get registered, and then we can set the appointment. They can get the appointment within a week, but that week to 10 days to get registered is, I would say, the only negative. If we were larger, we could have an API, which would mean we could register and get the appointment immediately, but it's very expensive. So right now, we're getting the nonprofit rate, which is wonderful. And so for us, it's the pros outweigh the cons.
Can they self-refer, or do they have to actually go to do they have to go through a
No, this program, you could sign up on your own.
So
You would pay a little bit higher rate, but it's something that big corporations sign up all of their employees as a benefit. So in addition to the mental health and Trek Health is the group we work with, their providers are through Pop-Up Doc. Teladoc. So they also, for that $12.50 a month for our patients, they have an urgent care that they could call on the weekends if they had an ear infection, a UTI, without having to go to urgent care of the hospital because they do not have insurance and are low income. So it provides an outside of our primary care if they have an emergency, and the clinic is paying for them the $12.50 a month right now. So it also provides an urgent care possibility for them.
I'm going to talk on behalf of the students, and it's very difficult for students to find any kind of therapist that's available. They have to wait, 2 months, sometimes 3 months to get just, a primary appointment. The intake process is not so bad. It's just trying to get to the therapist. We do have several students that do the virtual telehealth. They do that in their cars sometimes. We try to make room for them in the school that's overpopulated and we don't have enough rooms, but we do try to make it work. And we had a big blow a couple weeks ago. We just lost our in-school therapist, Rebecca Woods. She will no longer be working with Port. Apparently Port has merged with Easter Seals, and with this merge there have been a lot of changes. So that takes away the students that she was seeing on a weekly basis, and I will say that it's very popular and these kids really, really liked her, and so it's been a really big blow to the school system, at least for us. And she was also seeing kids in the middle school. So I think that this is a population that if we can work with them early, we won't have to worry about them as an adult. And I just feel very strongly about supporting them.
I got one thing I want to say. I would like for this board to take on a challenge of how we can reach and be more inclusive with the resources that we know about. The different programs. And if I'm wrong, show me your numbers. I'd like to see how inclusive we can be. Cool.
It's getting late.
Yeah.
Pastor Todd, I'm going to try to wrap it up real quick. July is our, the clinic's open for a year. I'm going to go back to the Manteo Board of Commissioners and give a report of what's occurred in that year. Because without the leadership of the Manteo Board of Commissioners, our group would not be here. Today is an important day for me. If you look around the room and see who's represented at the table in healthcare, there, as you know, McCrory's administration, he used to talk about towers, you know, governmental towers, and they don't ever talk to one another. While there is competition for patients, what we have only been about is access, no matter who provides care. And y'all are providing that care. And Ronnie, to see you and Lynn here today is a big deal. It's important. And I could go on and on about that. But to have an opportunity for y'all to talk and hear what's going on, maybe it's used competitively, but it's only used to help people. And I hope we can continue this. We were formed for whatever reason to address healthcare. I always know God has his purpose to help people. And I think y'all are doing that. But to be able to sit down at a table and look at each other and say, how can I help people? How can we work together to help people? I think that's important. And that y'all might not think it's important, but I do. So I want to thank you all for being here. I'm going to send you out a change in the organizational chart that Charles said. You know, we have changed. I'm going to send this out. You'll see that in your inbox. Thank you all for your time. And if there's a motion to adjourn, we'll adjourn. Second.
Yeah. Thank you, Malcolm.
Thank you.
Thank you.
All right. All right. Thank you all.